Yes, sir.
Is this full screen, Kishan?
1 minute, sir.
Yes.
Sir, can I start?
Wait for 2 minutes. It's 8:58 completed now. Just wait for 2 minutes.
How do you like a case being said in the beginning itself, nephrology case? We have to see the child as a whole. That is my principle. So we should not give this thing, focus some on one particular organ. The same organ may be involved, but there may be other problems in the other organs also. So better you mention that I am presenting a child with such a complaint or something like that. Or
Yeah. Initially, our
No.
this one, but in the roster, it was mentioned the case.
how does
this thing.
Balasubramaniam, what is your opinion? And Mahesh, Mohite, and Satish, you like it when somebody says that I am
I
presenting
totally
an
agree.
astrology
I
case
totally
or
agree.
something
In
like that?
fact,
You
in
agree
fact,
with
in the
me, sir?
open forum like that, absolutely. In the open forum like that, we prefer not to get cases even on the
Yeah.
panel discussion. It's
That
always
is why I
better
have seen
because
some of the
that releases more thought
yeah.
provocation.
Some of the
Because
specialists, they are missing some of the
I
other
would
thought system.
now
Yeah.
you
Dr. Nivedita is joined. Good evening, Dr. Nivedita.
Good evening, Dr. Nivedita. How is your new place, Kolkata?
Good evening, sir. Settling down, sir.
Good evening, doctor.
Good evening, sir.
Good evening. Nice that you are here.
Sir.
Calcutta is just out of Ramel just now, 2 days back.
Yeah.
Cyclone was there, no? Ramel cyclone. Too much.
Yes, sir. Yes, sir. It was this weekend, sir. It was a big cyclone. Yeah. Yes, sir. For
they
2
have
days.
voting cyclone tomorrow. They have
Yes, sir.
voting cyclone tomorrow.
Yes, sir.
Kishan, you can start with the introduction for yourself.
Hey everyone, myself Dr. Kishan Patel, pediatric resident from Apollo Hospital, Navi Mumbai. And
please go ahead. Please go ahead.
Thank you for this great opportunity. I am presenting today nephrology case. So I will start with my history. A 3-year-old boy, first born to the third consanguineous parents from Navi Mumbai, informing being mother with complaint of puffiness of eyes and face since 1 month, swelling of lower limb and upper limb since 3 weeks, abdominal distension and external genitalia swelling since 2 weeks, reduced urine output since 1 week. History of present illness. 3-year-old male child, first born to the third consanguineous marriage, was brought with complaint of puffiness around the eye and face since 1 month. Insidious in onset, gradually progressive, from initially involving the periorbital region to the whole face, more during morning hours, and then decrease as the day progresses. Then mother noticed swelling of the bilateral lower limb after 5 to 7 days, insidious in onset, gradually progressive from feet to knee, then upper limb from hand to elbow, more during morning hours, then decrease as the day progresses. After 4-5 days, mother noticed generalized abdominal distension, insidious in onset, gradually progressive, which later went on to involve external genitalia. There was no associated abdominal pain. Mother noticed reduction in both frequency of amount of urine passed since 1 week. Initially passed 6 to 8 times per day and presently passing 3 to 4 times in reduced amount. Mother noticed high colored urine. Negative history, no issue of breathlessness on exertion, chest pain, recurrent respiratory tract infection, decreased physical activity, reduced appetite, failure to thrive, jaundice, blood in vomiters, or blood in stool or urine. No issue of cola-colored urine, headache, or blurring of vision. No issue of recurrent infection, weight loss, body pain, blood transfusion, skin lesion, rashes, joint pain, drug intake. No issue of crying during micturition, and no issue of fever. Past history. Child was apparently normal 6 months back. He had similar complaint of puffiness of eye and face, progressing to involve lower and upper limb, followed by abdomen and genitalia. He went to local clinic, was admitted for 3 days, where he was given IV medication, then oral medication, was advised for 4 months. But he discontinued after 2 months, as the swelling subsided within 2 weeks. After that, child was asymptomatic for 3 months. Since then, child was not on any regular medication. Regarding the birth history, the child is first born to the third degree consanguineous marriage, no fever, rash, or any maternal illness during the pregnancy. Anomaly scan was normal. Place of birth was Navi Mumbai. Mode of delivery, normal vaginal delivery. 39 weeks of gestation, cried immediately after birth. Birth weight was 2.9 kg, no respiratory difficulty, jaundice, sinuses, or CT. Developmental history, all developmental milestones achieved till date. Immunized history. Immunized up to date as per national immunization schedule. BCG scar present and optional vaccines not taken. Diet history. Exclusive breastfeed till 6 months of age. Complementary feed started at 6 months of age. Currently, child is taking mixed diet. As per 24-hour recall method, calorie consumed is 770 kilocalorie. Required is around 1200 kilocalorie. Deficit 430 kilocalorie, around 30%. Protein consumed 20 grams, required 26 grams, deficit 6.5 grams. Family history, 6 members, grandparents, parents, and 2 kids. Sibling is 11-month-old healthy boy. No issue of similar complaint, tuberculosis, or any congenital disorder. This is pedigree, 35-year-old father, 22-year-old mother, patient being 3-year-old, and sibling 1 year. Socio-economical status, lower middle class according to the Kupuswamy scale. Summary. 3-year-old child, full-term normal vaginal delivery, was normal, developmental immunized till date, came with complaint of puffiness around the eye and face for 4 weeks, progressing to involve bilateral lower and upper limbs in 3 weeks, abdominal and external genitalia swelling for 2 weeks. With this, would like to consider the child is suffering from first relapse of idiopathic nephrotic syndrome. We did not find any obvious secondary causes. Most probably, minimal change nephrotic syndrome, no complication pending the examination.
Excellent. Okay, Kishan, your presentation of the history has been pretty good. But of course, with somebody like Professor Srinivasan around, there is always room for improvement. You please go to the first slide. Please go to the first slide in your history. You started with the statement. You started with the, just keep this slide on.
Yes.
3-year-old child, who has, as per your first slide, 4 symptoms. Okay, each of a different duration. First is a puffiness of face and eyes. Second is lower limb and upper limb swelling. Third is upper abdominal distension and genital swelling. Then reduced urine output 1 week. Now, You have always, Professor Srinivasan would agree with me, when you start your history of present illness, when did the illness start? That's the foremost question for me. Okay. And any symptom, you should always start after saying when the problem started, whether the child was absolutely healthy before. Some statement could have been made. Will you say definitely in this child, this 3-year-old who was well till the onset of this illness, develop puffiness of face? Will you use that statement or not in this child?
I did not use sir.
Huh?
I did not use that sentence, sir.
You will not use or you will use?
I will use, sir.
You will use. Okay. So you could have started the statement that this child who was apparently all right. But then, if you say apparently all right, you are contradicting yourself. How are you contradicting yourself?
Because he had past history of
Only 3 months back, this child has got a similar episode.
Yes, sir.
So, how would you have correctly started the entire opening statement now? How would you modify now? Now I am giving you a clue.
Child was apparently all right 6 months back, 4 months back, and it started episode of.
No. See, after recovering from a very similar illness 3 months back,
Yeah,
or
excellent.
apparently recovering from a similar illness 3 months back, this 3-year-old girl presented with the following complaints. That's how I would have started, indicating to the examiner that you have taken the history, you have taken cognizance of the fact that similar episode had occurred earlier. Okay, so indicating to the examiner that the illness in this child had started not just 1 month back, but had started way back 4 or 5 months back, apparently went into remission, and then it had recurred. Okay, that is comment number 1. Then the third comment I have a question to you. You have said swelling of the lower limb. After the swelling of the lower limb appeared, the next place to get swollen was upper limb or abdomen?
The lower limb and upper limb started around simultaneously. After that, abdomen swelling was there.
Oh, okay. Abdomen. After that, abdomen. Okay. What does this order tell you? Is there a clue from this order of first face getting involved, eyes getting involved, then lower limb, upper limb, and then abdomen?
Sir, regarding the eye, the soft tissue is more around the eye.
What does this order? How important is this order in terms of a clue to the cause for the edema?
Sir, cause for the edema is probably renal origin edema.
Renal. Very good. Okay. And reduce urine output since 1 week. Yeah, please go to the next slide. This indicates that this, okay, fine. Yeah. Then, was brought, no, don't go to history of present illness. Okay. Okay, again, right. Please go to the next slide. Okay, right. Reduction, everything, reduced urine output, oliguria is there. Then you had put high colored urine. I don't know. I've been telling in different classes also. What do you mean by the term high colored urine? I don't like the term at all. I'll tell you why I don't like the term. What do you mean by high colored urine?
Sir, it was a dark yellow colored urine.
You could have said that. Okay. Do not use the term high colored urine. There is no such thing as high colored urine. You exactly specify what is the color of the urine. In this child, was it yellow or was it amber or yellowish tinge was there? What is it? Is it bilirubin causing the change in color or high color? Bilirubinuria?
No, sir. It's concentrated urine.
Concentrated urine. You could have mentioned that clearly instead of saying high colored urine. Hello? Hello? Hello, please. Satish, please mute that person. Okay. You could have mentioned that.
Highly yellowish urine. Because when you say colored urine means immediately we are thinking of hematuria and other things. So that this impression you should not give. Okay, especially in a child who is having,
Okay. Amber color urine or slightly more dark than usual. Okay, right.
And the amount being less,
Less. Okay, right. Next slide. Okay. It's a female child, am I right?
Male child, sir.
Male child.
negative history is very good, but justify each and every statement. No history of breathlessness and exertion. So
Okay. Now,
you have mentioned nicely, you just mentioned the reasons why you have mentioned. Yeah, please go ahead, Dr. Bala.
yeah, I'm going to go ahead and ask you several points regarding the negative history. Why you asked that? Why did you ask history of recurrent infections?
Sir, for cardiac origin
Cardiac?
origin
Array,
edema.
your first itself said there is no history of breathlessness. Where does cardiac problem arise? So I think it is irrelevant if you ask me, recurrent infection. The only way recurrent infection, in which way recurrent infection and renal disease can be connected? Or a child with
Steroids, sir.
steroids. 1, 2, HIV. HIV can very well cause membranous glomerulopathy and nephrotic syndrome. Well known to cause immunodeficiency.
Yes, sir.
Right, but otherwise, recurrent infection, I don't think. Why did you ask for bone pain?
Bone pain, sir, certain malignancy can trigger secondary
Malignancy.
leukemia.
Malignancy. Which malignancy? Leukemia. How many leukemias have you seen with this sort of presentation without breathlessness, a nephrotic renal presentation? Very, very unusual. I don't think I would have asked. Instead of weight loss, I would have only asked about history of weight gain. In this child who has got edema, I don't think I will ask for weight loss. I will ask for weight gain. Okay. And bony pain. Blood transfusion for what?
Blood transfusion is regarding any same, sir, leukemia, thalassemia, or anything. HIV,
you have
hepatitis
said
B,
the child was
hepatitis
all
C.
right before, 3-year-old child previously all right. Where is the question of thalassemia and things like that?
Hepatitis B, hepatitis C transfusion, blood transfusion related.
The only way the skin lesions could be relevant in this child is if we are thinking of a glomerulonephritis, a history of skin lesion like impetigo might be important. Rash.
Or henoxanlin purpura.
Henoxanlin purpura, or rarely hemolytic uremic syndrome with petechiae purpura, ecchymosis. Joint pain for what?
SLE and
Pardon?
autoimmune related.
Autoimmune disease, okay. Drug intake, what drug intake did you ask?
Drug intake, sir, NSAIDs, penicillamine gold, that can cause secondary nephrotic syndrome.
Okay, granted, how rare it is, penicillamine, okay, right, fine. No history of crying during micturition.
Sir,
Why did you
UTI
ask that?
itself can cause
Do
trigger.
you think UTI will present without, in a 3-year-old child, will present with 1 month of edema without any fever? I don't think it is relevant if you ask me. And you have said already there is no history of fever. Of course, you must remember that below 3 years of age, urinary tract infections may not produce any symptoms related to the urinary tract at all. There won't be dysuria. Okay. In infants and young children below the age of 2 or 3 years, even if there is pyelonephritis or cystitis. Okay. Go ahead, next slide. And in the, okay, now, okay, the edema had increased, right, fine, okay. Okay, past history, yeah. What does this past history tell you? What does this story tell you?
So past history, sir, tell me about there was a similar episode of edema. Child
There was
had
some renal edema which subsided, and the
after
medication given for 4 months, 4 months, discontinued. And how long after discontinuation the swelling started? 3 months. Okay. Okay. What was the total duration of the treatment? And you could have asked them whether it was steroid or not. Was it steroid?
sir, it was steroid, and
You could have mentioned that. Why you want to say oral medication? You could have mentioned child received steroids. You can actually mention the dose. Why is that
mother
important? Know the dose of the steroids and the way it which it was given, the way it was tapered. Why is that important?
it can tell about the probably type of nephrotic syndrome it was
It
treated
will give
or
you a clue to the relapse which had occurred in this child, whether it is because it was inadequately treated, okay, or inappropriately treated, whether compliance is okay. All those things could have been captured in the past history. You must have gone into depth about the medications because the symptoms are very few. Medication history is very, very important in this child. You must find out what was the dose of prednisone or steroid that was given. Okay. Whether there are any complications during the previous episode. That also you could have captured in the past history. Right? Okay. Go ahead. Next slide. Child was not on regular medications. You should have used the term how long? For the last 4 months. Am I right?
yes, sir.
Okay. After the initiation of the symptoms now, was the child put on any medication?
No, sir. Mother thought that previously.
Okay. Okay. Go to the next slide. Okay. Next slide. Birth history. Okay. Next one. Development. Okay. Okay. Don't use the term optional vaccine is no more used. Use only say she was immunized as per the national immunization schedule. That's all. Other vaccines were not given. In private sector vaccination were not given. Okay, diet. Diet, 1 minute. Was the child restricted to was the child restricted on salt intake?
No, sir.
That you could have mentioned. Right? Next slide.
Yes, sir.
Family history, okay. Go ahead. Okay. Okay. Right. Now, before you come to a conclusion that this is nephrotic syndrome, I'm going to ask you a few questions. Because the standard question that we ask in the exam, I'm sure Professor Srinivasan would agree. Is this nephritis or nephrotic syndrome?
Sir, probably nephrotic syndrome.
What are the differences in the history and physical examination between nephritis and nephrotic syndrome? Differences in the history as well as physical examination. Though we have not done a physical exam, I'm just trying to orient you for the exam, orient you to the exam pattern of questioning. I'm sure Professor Srinivasan would agree.
Yeah, absolutely.
The differences between nephritis and nephrotic syndrome in terms of symptoms as well as signs.
The age of the presentation is common with nephrotic syndrome. 2 to 6 year, child is 3-year old.
2 to 6 years nephrotic syndrome. If you ask me, it is 1 to 3 years. Maximum, most nephrotic syndrome occur between 1 to 5, mostly between 1 to 3 years. Okay? Right. Okay, one.
And
Nephritis.
more than 6 years, sir.
Okay, age then?
Chudmona, 3
male
years old
pre-
child with normal development, immunized till date, came with complaints of puffiness around eyes and face for 4 weeks, progressing to involve bilateral lower and upper limbs since 3 weeks, abdominal and external genitalia swelling for 2 weeks, Cecil sir, join here. With this, would like to consider the child suffering from first relapse. First relapse of idiopathic nephrotic syndrome. We did not find any obvious secondary cause. Most probably minimal change nephrotic syndrome. No complication pending the examination. నాకు తెలిసి అయిపోయిందా ఏంటి ఆల్రెడీ అంత డిస్కషన్.
In the previous admission also you have to mention how long the child was kept in the hospital. Okay, because nephrotic syndrome they usually keep for this thing till the albumin disappears. So hospitalization will be there anywhere between 10 to 2 weeks to 3 weeks. And then of course where the type of doctors they go, because in India there are so many types of doctors. So the village they may go to a non-allopathic doctor. So why can't you mention some of the details from the parents? Are they educated parents or uneducated parents?
Illiterate.
Yeah. So you must mention that the duration of admission and the time taken for the previous episode to disappear and what type of advice they have given, you can always mention. Because you said that they haven't continued the drugs. I'm sure, if a regular doctor is there who has been treating a pediatrician, definitely would have mentioned how long to be given and how it has to be given. There's nothing wrong in mentioning these details. Okay. Yes.
Yes, sir.
Now, a few things in the history. You nicely presented all the details of development diet. What was missing in your history? For me and process, as always stress, you never mentioned anything about the weight of the child, the length of the child, or height of the child, and the head size of the child.
Yes, sir.
Is it
It's in the
important or not?
anthropometry. Yes, sir.
Particularly in a child.
No. You can ask the parent,
Parents,
they must have seen so many children of the same age group. So whether the child, especially, so you can ask, because height is very important, especially when you're giving treatment. Okay.
Yes.
So
There are two
naturally you can
children.
ask. We always ask about developmental milestones in the history, but we never mention a word about. See, nowadays, there is a MCP code. Even villages, all the Anganwadi workers, they plot the height and weight and then tell the parents, the color. You have seen MCP code, Maternal Child Protection Card, which is given to all the parents in villages and this thing. So they are supposed to tell the village people, mother and father, this is how the child is growing. If anything is flattering or it is coming down. So when things have gone so much, you can always mention about the growth of the child also, because after all, when we are giving steroids for a long time, that may affect the growth pattern. Okay. Yes.
Yeah, it is very, very important to find out details about the weight. Because what can happen is that a child who has multiple relapses, instead of becoming obese due to steroids, may also become malnourished because of severe recurrent proteinuria. That is one. Two, a child who has recurrent nephrotic syndrome may also become obese due to the steroid therapy. Three, a child with nephrotic syndrome who has multiple recurrences may become stunted because of the disease as well as because of the steroid therapy. And four, of course, not in this, I'm not going to think about it. If there is onset of nephrotic syndrome in the first 1 year, I would also inquire into the details of the head size of the child.
Yeah, there are two conditions with microcephaly.
Yeah, you can have microcephaly due to a congenital CMV infection or even a congenital perinatal HIV infection. Okay. Which
There are
can
genetic conditions also, two genetic conditions with nephrotic syndrome having, with genes are involved, yes.
Finnish type congenital nephrotic syndrome. Okay. So
Yes.
it's very important to find out the details of the weight, height, as well as the head size, particularly in parents who have two children like this. They have one more child. I'm sure they would give you details of this child's height, weight, etc. if you go into the details, and they can give very significant clues to the etiology of the nephrotic syndrome and the severity of the relapses, etc. Okay, right. The next thing is, in fact, before we go to the physical examination, you have still not given me the differences between nephritis and nephrotic syndrome from history and physical examination. Other than age.
Male predominant, sir.
Hello?
Nephrotic male predominant.
Your voice is not very this thing, distant it is.
And sir, in the nephrotic, it's more of a proteinuria.
Okay.
Presented with edema, and in nephritic, it's a hematuria, sir, mainly.
Okay. What about the onset of illness? Is there any difference between the way the disease presents, the speed at which symptoms and signs develop in nephritis and nephrotic?
In nephrotic, it's a gradual.
Yeah, it is usually insidious. Somebody has put in the chat box. Yes, in nephritis, it is usually acute. In nephrotic, it is subacute. Right? So age, mode of onset. Then what else? In whom there is more anasarca, nephrotic or nephritis?
In nephrotic, sir.
Nephrotic. Hypertension.
Nephritis, sir.
Gross hematuria.
Nephritis, sir.
Okay. Cardiac complications like left ventricular failure, respiratory distress.
More common in nephritis, sir.
Nephritis, more in nephritis. Okay, right?
Yes, sir.
History of an acute febrile illness in the form of a respiratory infection 2 to 3 weeks, or history of skin lesions preceding the illness. Nephritis again. Nephritis again. Right? Nephritis.
Yes, sir.
Okay. And on a similar note, any child who's ill is likely to have nephritis or nephrotic. Ill child nephritis or nephrotic?
Ill child nephritis, sir.
Nephritis. Ill child nephritis. Usually children with nephrotic syndrome are well.
Well, and active.
They are not sick children. And these are some of the differences. Okay. Sir, you want to ask more questions, and I'm sure
You can continue.
Mahesh,
Yeah.
Mahesh, you have anything to question? Mahesh Mohite? Okay. You go to the presentation, please.
General
Yeah.
examination.
Hmm.
Child was alert, playful, well looking, lying on mother's lap, examined in supine position, anasarca present, generalized edema was present with face and
That's
cerebral
severe anasarca or very mild anasarca?
Sir, it was severe at this.
Okay. Hmm.
Abdominal distension, scrotal swelling, lower.
What
and
about
upper
the
lip.
nutritional status by appearance?
By appearance, child is somewhat malnutrition. Sir.
Somewhat. You could have mentioned that in spite of the anasarca, the child appears not well nourished. You have the picture of the child?
No, sir.
Okay. It would be very useful to say what is the nutritional status by appearance.
Yes, sir.
Okay, go ahead.
Sir, vitals, temperature was 98.6 Fahrenheit, pulse 98 beats per minute, adequate volume, no delay, all peripheral pulse is felt. Respiratory rate around 32 per minute. Capillary refill time less than 3 seconds. Blood pressure 85/50, around 50 to 90%. Head to toe examination. Head was normal size and shape. Hair, hypopigmented, lusterless, and thin hair. Facial puffiness was present. Oral cavity, no ulcer. Dentition normal. No dental cavities. Tonsil and
What happened?
throat was normal. Eyes, pallor present. Ear, no discharges. Neck, no rashes. Chest, ribs are prominent. No rachitic rosary, Harrison circles, or pigeon chest. Umbilicus, normal position and stretch. Spine, normal. Genitalia, scrotal edema. Extremities, biliary edema up to knee and elbow. Skin is shiny over edematous region. No cyanosis, clubbing, or lymphadenopathy. No valgus, varus deformity, or anterior tibial bowing. Topometry. Weight for age was 10.8. Child length was 86 centimeter. Head circumference was 48 centimeter. Mid upper arm circumference was 12.5 centimeter. And expected range weight should be around 14 kg. Length should be around 95 kg. Head circumference 49 kg. So child is at weight for age at -2 to -3 standard deviation. At length, child is -2 to -3 standard deviation, and mid upper arm circumference, child is in malnutrition category.
No. On the basis of mid upper arm circumference, how do you classify the severity of malnutrition if at all the child is malnourished?
Less than 11.5 centimeter.
Then what is the normal mid-arm circumference?
Above 12.5 centimeters.
No. Actually,
Yes.
15 centimeter is the age independent
Criteria, mid-arm
criteria
circumference,
between
yeah.
1 to
And
5 years.
0.25 centimeters every year till 5 years.
Yeah. 1 to 5 years, it is 15 centimeters. And anything less than 13.5 is malnutrition.
And
12.5
11.5 is severe
Yeah.
malnutrition.
12.5 to 30, anything, see 12.5, you can call it as moderate malnutrition. There is no mild malnutrition per mid-arm circumference. It is less than 12.5. You always say it is moderate malnutrition. 11.5 is the cutoff criteria for SAM. So this I would say moderate PEM based on mid upper arm circumference. Okay.
Yes,
Since
sir.
child is 3 years old and fits, and your MAC is an age independent criteria, you can use to classify this as probable moderate malnutrition.
Those days, in the villages, bangle test was done. And also the Shaki's tape, you must be knowing,
Yes.
which are very commonly being used. So you must know that, yeah, okay. Have you seen Shaki's tape?
Yes, sir.
Okay, yes.
Go ahead.
It's kept in this thing, OSCE stations, yes.
Go ahead.
Systemic examination. GIT examination in supine position. Inspection. Abdomen distended uniformly, flank full. Umbilicus central and stretch. No scar. Superficial dilated vein present. No visible peristalsis or pulsation. Scrotal penile edema present. No redness or ulcer on the scrotum. On palpation, pitting edema present. On deep palpation, liver, spleen, kidney are not palpable. No tenderness. Abdominal girth 53 centimeter. On percussion, shifting dullness present. Auscultation, normal vowel sound are heard. In respiratory examination, normal vesicular breath sound, heard bilateral equal air entry, no added sound. In cardiovascular system, S1, S2 heard, no murmur. In CNS examination, no focal neurological deficit.
Go ahead.
So my diagnosis would be first relapse of idiopathic nephrotic syndrome, most probably minimal change nephrotic syndrome without any complication, along with nutritional anemia with malnutrition.
Okay. What is the severity of malnutrition?
Moderate malnutrition.
Okay. Right. Now, why do you think that this child is, why do you think this child has got idiopathic nephrotic syndrome? And again, you have put most probably, you have put it as minimal change nephrotic syndrome.
Yes, sir. Idiopathic because of the negative history, there was no obvious secondary cause to be found to cause nephrotic syndrome.
So that's why you call it as
Idiopathic.
Idiopathic. Okay, right. Now, what are the differences in the clinical presentation between idiopathic or minimal change disease and other forms of nephrotic syndrome?
So in such other form, there is a trigger after a toxin, drug, or any infection. Secondary, after that, nephrotic syndrome present.
What are the other conditions which can cause nephrotic syndrome other than idiopathic or minimal change disease?
In other conditions such as any infection, torch infection, hepatitis B, C, after infection, or any exposure to drug or toxin.
Other than that, infections such as hepatitis B, C, HIV, okay, even EBV, CMV can all cause nephrotic syndrome. Malaria, quartan malaria can cause nephrotic syndrome, right? As you said, drugs and toxins, even snake bite and scorpion sting, heavy metal poisoning, all can cause nephrotic syndrome. Okay, you can get nephrotic syndrome secondary to lymphoma, right? You can get nephrotic syndrome secondary to renal vein thrombosis. Somebody says leukemia. Much more common than leukemia is is lymphoma. Okay, you can get it in renal vein thrombosis. Whatever the etiology is, you can get nephrotic syndrome. You can get nephrotic syndrome due to metabolic disorders like Wilson's disease. Yes, vasculitis like SLE can very well produce nephrotic syndrome. Well-known complication of SLE is nephrotic syndrome. Heavy metal poisoning can result in nephrotic syndrome, right? So these are all some of the other conditions which can cause nephrotic syndrome. Okay, of course, IgA nephropathy can also cause nephrotic syndrome. Membranous glomerulopathy, whatever the cause, can lead to nephrotic syndrome, right? Yeah, amyloidosis. Yes, chronic amyloidosis, yes, can cause nephrotic syndrome. These are all some of the causes. Okay, in this child, it is very likely that this is minimal change disease, and it is very likely this is likely to be a relapse of the nephrotic syndrome. Okay, right. Now, what do you do for this child?
So first investigation.
What investigations will you do? And what did you do and what did you find?
The urine routine.
Hmm.
So in urine routine, protein was 4+, sugar was nil, WBC 6 to 8, RBC 15, epithelial was 1 to 2, sir. So in urine routine, it's
what is the if what is the criteria to say somebody has got a relapse? What are the criteria to say the child has got a relapse?
So in spot urine protein creatinine ratio more than 2 milligram per milligram, or
What should be the urine protein creatinine ratio above which you consider it as abnormal?
so sir, less than 0.2 is a normal, 0.2 to 2 is a nephrotic range proteinuria, and more than 2 is a nephrotic range proteinuria.
Very good, very good. You can say a nephrotic syndrome child has undergone a relapse if the urine protein is more than 3 plus, or for 3 consecutive early morning specimens, you must demonstrate a more than 3 plus proteinuria, or you must demonstrate a urine protein creatinine ratio more than 2 milligram per milligram. Okay. In a child who has been in remission, if there is urine protein creatinine ratio more than 2 for 3 consecutive days, or proteinuria 3 plus or more for 3 consecutive days, you call it as relapse. Okay? Before you term a child is having relapse, you must have this criteria. Okay, 4 plus, even a single specimen with massive edema. Yes, right. What about the deposits 6 to 8 and RBC 0 to 15? What is your comment?
It was in 20% cases, microscopic hematuria can be present.
In 10% of children with nephrotic syndrome, 10% of children with even minimal change disease, there may be microscopic hematuria or pyuria or minimal hypertension, which is transient. Okay, right. Go ahead.
Well, serum albumin was 1.3
Hmm.
and cholesterol was 400. Sir.
Okay.
And in the CPC, hemoglobin was 11, PCV 40.
Suppose there is hematuria in this child, what other investigation should you do? Suppose you find there are 20 RBCs, same story, albumin is 1.3,
The complement levels.
complement C3 level, because reduced C3 levels is very much in favor of a nephritic onset of nephrotic syndrome. It doesn't occur in minimal change disease or idiopathic nephrotic syndrome, C3 level. Of course, you don't do it routinely as part of workup for nephrotic syndrome, but if there is hematuria, gross or microscopic, you should ask for C3. And lowered C3 is also one of the indications for renal biopsy if you have child with nephrotic syndrome. Okay, go ahead.
Hemoglobin 11,
Hmm.
PCV 40, total count 15,300.
What is your comment on the PCV 40?
So, child is on mild dehydration, sir.
It indicates that there is
Hemoconcentration.
hemoconcentration because of edema. Plasma leak is occurring just like dengue. You must remember 3-year-old child PCV of 40 and the hemoglobin of 13.3. Of course, and the hemoglobin is 11. PCV 40 indicate that there is some third spacing occurring in this child, secondary to the low oncotic pressure and hypoalbuminemia. And what is the importance of this in terms of complication?
So, in nephrotic syndrome, dehydration to low carb,
This is
shock
one of the
and
risk factors for thrombosis, one of the risk factors for thrombosis. And in these groups of children, if you give diuretics, it can be disastrous. You will end up producing thrombosis. Already there is hemoconcentration, so you must be very, very careful and avoid giving diuretic for such patients who have massive edema without respiratory distress and hemoconcentration. Okay, go ahead.
electrolytes, sodium 130, potassium 3.6 and chloride 100. And urea was 134, serum creatinine 0.7.
Sodium and potassium both are on the lower side, isn't it?
Yes, sir.
Okay, okay. Urea 134, creatinine 0.7. What is the, did you calculate the GFR? Hello?
No, sir.
You should calculate the GFR in such cases.
Yes, sir.
And here you see the creatinine is 0.7, but the urea is very, very high. Very, very high. Okay? Indicating, and with the PCV, there is a likelihood that this child's rise in urea might be because of a dehydration and pre-renal acidemia or an acute kidney injury secondary to dehydration. Okay, go ahead. Oh, what is the indication for furosemide in this child? When do you give furosemide in children with nephrotic syndrome? What are the risks of, we already discussed the risk of giving furosemide. What are the indications for furosemide? What is the indication in this child?
Sir, with a severe.
No, severe anasarca by itself is not an indication. Respiratory distress, massive ascites causing respiratory distress, or genital edema interfering with micturition are the only indication, or cardiac failure or hypertensive left ventricular failure are the only indications for giving furosemide. Otherwise, even in massive anasarca, in nephrotic syndrome, particularly with the PCV of 40, it is better to avoid furosemide. And people prefer metalozone rather than furosemide. Even nephrologists would prefer metalozone rather than furosemide because it's slower acting than furosemide. Okay?
Yes, sir.
Okay. What is the weight of this child?
10.8 kg, sir.
Okay. Okay. You started on prednisolone.
Yes, sir.
Okay. Okay.
So, prednisolone was started at 2 mg per kg for 2 weeks. After 10 days, we have done the morning urine dipstick test. It was a trace. So we have started to the 15 mg alternate.
What is the definition of remission? What is the definition of remission?
Remission is, sir, 3 consecutive morning urine dipsticks.
Nil or trace proteinuria. Nil or trace proteinuria or urine protein creatinine ratio less than 0.2 for 3 consecutive days is the indicator of remission. Okay, you have done it. Okay.
So after that, we have started the child on 15 mg alternate day for 6 weeks.
Go ahead. Okay.
So,
Now, what complications do you anticipate in this child?
so in this
What
child, sir,
complications do you anticipate in this child who has got a relapse of nephrotic syndrome? I would say first relapse.
normally complications are acute bacterial peritonitis, renal vein thrombosis, rarely hypertension.
Hypertension is not common. See, if you are asked what are the complications that you anticipate, the most important complication in nephrotic syndrome is infection. And you must also understand the reasons for the increased risk. The next question the examiner might ask you, what predisposes children with nephrotic syndrome to develop infection? What are the reasons children with nephrotic syndrome develop infection?
Sir, due to protein losses
Very
Hypoprotein.
good. Protein specifically, they lose IgG, they lose complement, they lose opsonin. Okay,
Yeah.
they are all low molecular weight protein, and nephrotic syndrome has got what is called highly selective proteinuria. They lose only low molecular weight protein, right?
Yeah.
Highly selective proteinuria, and they are prone to have low IgG, low complement, low opsonin, low propyridine. That is one reason. Two.
Steroids.
Hmm?
Steroid therapy itself can cause
Therapy
recurrence.
itself, you are giving steroids, yes, immunosuppression. 2, 3. Edema is a fantastic culture medium for infection.
Okay.
4. Because of chronic hypovolemia due to interstitial edema and third spacing, there is functional hyposplenism. Spleen does not receive adequate blood supply. The maturity of function of spleen is poor. Okay. Next, synthesis of immunoglobulins is reduced because of hypoproteinemia. The liver dysfunction occurs. It doesn't synthesize immunoglobulin as well as before. Right? And of course, if there is severe anasarca, if you give rest, bed rest is another risk factor for infection. These are all the reasons why infections do occur in nephrotic syndrome. Why do they develop thrombosis?
Sir, yes, sir.
Why do they develop thrombosis?
Loss of complement.
Loss of complement leads to only infection. Why?
Due to low oncotic pressure and
Low oncotic pressure and hypovolemia
hypovolemia.
and increase prothrombotic factors and increase production also. Okay. All this leads to hemocondylitis, leads to increased risk of thrombosis.
Bed rest.
You must remember nephrotic syndrome. Children are prone for hypothyroidism, prone for vitamin D deficiency, prone for hypercholesterolemia, prone for accelerated hypertension in young age. All this is hyperlipidemia. All this is reported. Right?
Yes, sir.
Yeah, please explain the nomenclature that you have put in this slide.
So regarding the remission, so for remission, urine protein should be nil or trace for 3 consecutive early morning specimen, or spot protein creatinine ratio less than 0.2 milligram per milligram, or protein excretion less than 4 milligram per meter square per hour.
Okay.
For relapse, urine protein should be more than 3 plus for 3 consecutive early morning specimen, or spot urine protein creatinine ratio more than 2 milligram per milligram, or protein excretion more than 40 milligram per meter square per hour, having been in remission previously.
Yeah, very important to know that to label a child as having relapse, there must be documented remission earlier. Okay? Right.
Frequent relapse, 2 or more relapse within initial 6 months, or 4 or more relapse in any 12 months.
In this
point is very important.
Yeah,
what you said is very important. Remission should have been documented before you say, because inadequate treatment is one of the important causes. It's not called relapse. Okay, yes.
Yeah, is this child having frequent relapse?
No, sir.
Okay. Okay. Go ahead.
Steroid dependent, 2 consecutive relapse during corticosteroid tapering therapy or within 14 days of its discontinuation.
Okay. Okay.
And steroid resistance, absence of remission despite therapy with prednisolone at dose of 2 milligram per kilogram per day for 6 weeks.
Some earlier it was even some authorities considered even 8 weeks. Today it is restricted to 6 weeks. Okay. Go ahead.
Other treatments, sir.
What is the dose of prednisolone do you give for initial treatment of nephrotic syndrome, and how do you give?
2 milligram per kilogram per day.
No, it is not based on milligram per kg. It is based on
60 body surface area.
60 milligram per
Milligram
square
per-
meter body surface area. You give it as a single dose or 2 or 3 divided doses?
It's as a single dose, sir.
No. Again, initial treatment study, the ISKD says it is better to use divided doses. The efficacy of divided doses for initial treatment of nephrotic syndrome for the first time is superior to single dose. Only for alternate day steroids or for relapses, you use a single dose. Initial treatment, any first episode of nephrotic syndrome, it is better to use 60 milligram per square meter in 2 or 3 divided doses for more efficacy. Right? Go
Yes,
ahead.
sir.
Go
For
ahead.
frequent relapse, so presenting attack must be treated as a fresh case till remission, followed by longer therapy for 6 to 12 months with any of the following. As a low dose alternate day, single morning dose prednisolone for 9 to 18 months. Dose of prednisolone reduced gradually to minimal possible, required to keep patient albumin free to minimize side effect. And second, low dose alternate day, single morning dose prednisolone at 0.5 milligram per kilogram per day with a steroid sparing drug levamisole 2 milligram per kilogram per day for 12 to 24 months. Addition of this agent is indicated in case who need more than 0.5 milligram per kilogram per day of prednisolone to control proteinuria.
Go ahead.
Other medication are cyclosporine and tacrolimus in steroid resistance cases.
How do you treat a relapse?
Sir, if it's a first relapse, we will treat as a fresh case until remission, sir.
Then what do you do?
After that, we will start with a alternate day steroid therapy for 6
How much
weeks.
alternate days? 1.5
Sir,
milligram per kg
1.5
alternate
milligram.
days for 4 weeks.
Yes.
Okay, 4 weeks. If it is an infrequent relapse, you can treat each relapse for 4 to 6 weeks. Okay. If it is frequent relapse or if there is steroid dependence, then long-term therapy with prednisolone on alternate days, as you said, low dose, single morning dose, 9 to 18 months. Okay. If there is any evidence of steroid toxicity or steroid dependence, what do you mean by steroid dependence?
Sir, relapse after shift to alternate therapy or stop of steroid therapy
Stopping
of
or
within
lowering
14
of
days.
dose, lowering of. For you have multiple alternatives starting from levamisole, which is the cheapest drug available. Then you have mycophenolate moxetil. Then you have the toxic cyclophosphamide. Then you have tacrolimus or cyclosporin. Last but not the least, you have rituximab. Of course, all these drugs are beyond the scope of any general pediatrician. You should discuss with the pediatric nephrologist and start the appropriate therapy. What is the diet that you will give to somebody who has nephrotic syndrome? What is the dietary advice you will give to the mother?
Sir, high protein, salt restricted diet, sir.
What about salt?
Low salt, sir.
No salt in the diet.
Low salt.
Low salt or no salt or normal salt?
Low salt, sir.
No salt or normal salt or no salt. I am giving you 3 choices. Many are putting in the chat box. The important message is, for an uncomplicated case of nephrotic syndrome, you can give normal diet. Normal diet. There is no need to restrict salt. Salt restriction is required only when there is severe anasarca or severe hypertension or renal dysfunction. Otherwise, salt restriction is not routinely recommended for nephrotic syndrome. Nor is there a need to restrict fluid. You can give normal diet. Unless there is massive anasarca, hypertension, cardiac failure, there is no need to, or renal failure, there is no need to restrict either fluid or salt. High fat diet, saturated fat should be avoided. Okay. Right. Okay. Anything else you have to present?
Indication of renal biopsy.
Yeah. Go ahead.
Steroid resistant nephrotic syndrome
Yeah.
or progressive renal failure, unexplained persistent hematuria or proteinuria, secondary nephrotic syndrome, or hypocomplementemia.
I think even before administration of calcineurin inhibitors, if I remember correct, I think biopsy is indicated. Am I right? I don't remember. I think before initiating therapy with calcineurin inhibitors, you are supposed to do a renal biopsy.
Yes, the steroid resistant.
Okay. Right. Next. Right. Sir, Professor Srinivasan, sir, you have any questions to ask?
You have covered almost all the questions which will be
stop
asked.
Sharing. Dr. Manish, you can stop sharing.
Yeah, already mentioned all the points which will be asked in the question. Of course, a diagnosis will be easy on seeing the patient. And when a case is given, it can, there are so many googlies that can be bowled in nephrotic syndrome and they expect you to tell because it's not a uncommon problem. So, of course, there are guidelines which have been 2011, subsequently, recently, it has been modified. And you have to know all the definitions and everything has been discussed in detail very well as usual, by Dr. Bala.
Yeah. Manish, any questions from your side? Any doubts? Will you do an ultrasound for this child?
Yes, sir.
What for? What is the usefulness of ultrasound? How does it help in the management?
Sir, to see basic anatomy.
Actually, as per the protocol, nowhere it is mentioned. No need, unless you are expecting a complicated nephrotic syndrome like renal vein thrombosis or a tumor, Wilms tumor, or a space-occupying lesion causing nephrotic syndrome, or you are not sure about the diagnosis. There is no need for looking for doing an ultrasound.
And for biopsy, of course, you have to do.
Biopsy, yes. The only way ultrasound may give you a clue to the etiology of nephrotic syndrome is by picking up the corticomedullary differentiation loss, which will occur if it is a nephritic type of nephrotic syndrome. Okay, and if an ultrasound can pick up a renal vein thrombosis, other than that, it's not indicated. Right? Of course, in India, you must do a tuberculin test and an X-ray test before initiating steroid therapy. Right? That's very much required in the Indian setting, where you may aggravate pre-existing tuberculosis if the child has been exposed to tuberculosis. Okay.
Right. Less than 3 years, if a child is having this thing, a family history, not only in one generation, but you have to ask, because there are now a lot of genetic forms of nephrotic syndrome being reported, not responding to treatment or not going to relapse at all, remission at all, and frequent, especially less than 3 years is very important. And of course, earlier, Dr. Snehal also has mentioned this in one of the discussions on nephrotic syndrome.
Genetic locus for steroid responsiveness or steroid resistance is being described, and more papers are coming. Of course, it's beyond the realms of a general pediatrician. I'm sure specialist nephrologists will and the genetic experts will throw light on that. Okay. Right. Yeah, are there any other questions that need to be taken up? Any other comments from seniors or attending? Satish?
Dr. Snagel, if she is there, she can mention the nephrotic syndrome genetic
Sir.
types, Galloway-Mowat syndrome and
Yeah.
microcephaly, etc. Because I am sure you must be having a few cases.
Yes,
Sneha?
sorry, I joined late, but I have shared a reference which Sir Balasubramanian sir we had discussed last time. Also, I had shared that reference of genomic and clinical profiling. People can download it and save it, where they have more than 50 genes which are associated with steroid-resistant nephrotic syndrome and their clinical phenotyping. And
Yes.
so that paper is nice, and you can just refer if. See, if nephrologist does the report and comes back to the pediatrician with the report, then pediatrician also needs to understand what exactly the prognosis and it means. So you can have this reference saved with you.
Okay. Okay.
Yeah.
Okay.
What is the importance of patella in nephrotic syndrome?
The
If
main
the child
patella
is
syndrome.
between 3 to 6 years, yeah. Yeah, there are so many other syndromes which can occur in association, yes. Good.
Okay. Snehal, we have time for a small presentation on FAQs and rickets.
Yes, sir. Yes, sir.
That's why
Okay.
you have made it very fast, yeah, good.
Allow me to Satish.
Hello, sir. Actually, seeing one emergency patient.
No, I
So
sent
you
the
are
PowerPoint to.
co-host, no? So your co-host, no? You can share there down share
No,
button.
it's not. It's not. I'm not able to. I'm not able to allow. No. I don't know. No, I'm not able to open the thing.
I'll try from my side, sir. Just 2 minutes.
Satish? Hello? Satish, could you open the PowerPoint? Hello?
Actually, same problem is happening with me.
I'm not able to share it.
Yeah. Can I make you the host then and try?
I'll try.
Just a minute. I'll just.
Yeah. Last time you tried, I couldn't. That's why I sent you the WhatsApp.
Yeah, actually, I actually did not got the laptop today. I just had the other person laptop. That's why the problem is happening, sir. अभिषेक से बोलो तो ये ओपन कर अभिषेक जस्ट a minute. अपडेट होते हैं जब तुला पहले ऑन कर लगा नहीं हाँ पाठवलं व्हॉट्सअप जॉईन मीटिंग कसं करायचं हे माझं आहे ना हे वाला Sir, I try to make you one time host because this
No.
laptop is not taking this one.
I'll just see. You make me the host. I'll try.
Yeah. Okay.
I don't think it's possible.
Just a minute, sir. It says one try, sir, because this laptop is not working at this moment.
No.
What is it showing, sir? Message?
No. It is not opening. It's going to Dropbox, OneDrive, Google Drive, but it's not going to my laptop at all.
Just I'll try. Can just make me again host, sir.
Okay.
@Gmail. Gmail.
No, I don't think it is possible, Satish.
Sorry,
Last
sir.
time-
Actually, today my laptop is my child. She had one meeting, so I got.
Okay.
Hmm.
Okay, leave it. We'll put it next time because without the PowerPoint, I have X-rays and all that. It's okay, fine. Next time.
Sir, if
Next
you
Yeah,
can
time.
email, sir, if you can email to Dr. Satish, next time he can directly start with
Yeah,
that.
I'll directly present the first slide only, that one.
No, I thought, okay, fine, okay. WhatsApp, email, it doesn't make any difference, Nehal. I sent
No,
it.
no,
then.
I am just 2 minutes, sir. I just last try I'm doing.
And I also sort out this problem of others sharing next time with your
Yeah,
tech.
initially that is happening. The post, if you're making the first time, it is able to open. After that, is not able to open.
Hmm.
Because now I am not
Some
able to
technical-
open.
Yeah, some technical issue.
Hmm.
Okay, leave it. It's okay. It's okay. Okay, we'll have it next time. We'll have it
Sorry,
next time.
sorry, sir. I just make the next time. I'll
No
start
problem.
with that only, sir.
Yeah, no, you just ask the technical team to sort this out. Okay.
Yes, yes.
So
Okay,
next time
Manish,
we can start with your presentation and then students.
Yes, sir.
Yeah. No, but I that's why I sent it carefully, man. Today, Snail.
Yeah,
You asked.
actually, I'm really sorry
I
because
sent it.
yes.
It's okay.
No,
It's
this
okay.
such time sometimes it happens, so nothing to feel this
No,
thing.
actually, what is this technical
Fine.
issue? Now the
No,
doctors
no,
are supposed.
don't feel
Yeah.
bad, Satish. Not your fault. Anyway,
Sorry.
we'll
Yeah.
have a great time. Okay.
Okay. Thank you. Sorry,
Thank
sir.
you.
Thank
Good
you.
night. Good night, sir.
Good night, all
What
of
is the
you.
agenda
Yeah.
next? What is the agenda next time, Snehal?
The next is neonatal cholestasis and live vaccines.
Super. Okay. Good. Okay.
Good.
Thank you, sir. Thank you.
Thank
Good night.
Thank you. Thank you.